pharyngeal collapse. How many of you experience the collapse of the airway, pharyngeal collapse? You can raise the hand or you can unmute on mic and speak.
I think most of us have experienced, but maybe we are not interpreted it correctly.
Yeah. So we are predicting difficult airway in terms of difficult intubation, difficult laryngoscopy, difficult supraglottic airway insertion. But if you fail with intubation, if you fail with supraglottic airway devices, and if you are having a chance, you can easily come out by abandoning the procedure. But when you are encountering the pharyngeal collapse, you have to have an exit to overcome this collapse. And that is the reason predicting the airway collapse or pharyngeal collapse is more important than predicting the difficult intubation predicting difficult supraglottic airway devices. And why it is so important? Why we need to understand the pharyngeal collapse? So if you look at the pharynx, see there is a nasopharynx, laryngopharynx, and trachea, and in between there is an actual pharynx. So if you look at a nose, see nose is a rigid structure surrounded by a bone. So it's less vulnerable to change with the pressure. But if you look at the larynx or trachea, again, larynx is covered with the cartilage, trachea is covered with the complete CCF ring. So again, larynx and trachea also less vulnerable to change with the pressure. And to make the change in the laryngeal anatomy, it requires high pressure of 50 centimeter of H2O. But if you look at the pharynx, which is situated between the sort of a two semi-rigid structure, nose and larynx trachea. So this is a pharynx. Here, this is the pharynx. So pharynx is a tubular structure surrounded by a soft tissue within fixed bony enclosure. So it's surrounded by a soft tissue. So this nose is a rigid structure, larynx trachea is a semi-rigid structure, and in between that, pharynx is a tubular structure surrounded by a soft tissue which is vulnerable to change with the pressure. So there's the difference between the nasopharynx, laryngopharynx, and trachea with the actual pharyngeal structure, which is vulnerable to change with the pressure. That we should keep in the mind. So, and there are three narrowest portions of the pharynx. The structure behind the soft palate, that is retro-palatal space, behind the tongue, that is retroglossal space, and behind the tongue, that is retroglossal space, and behind the epiglottis, that is retroepiglottic space. And see, this is very old publication of almost 25 years old. They did a MR in awake patient and asleep patient in two groups. And awake patient, if you look at this, AB, CD, and EF. AB is a retropalatal space, CD is a retroglossal space, and EF is a retroepiglottic space. All this space is critically narrowed in asleep state. Look, here, AB, there is no gap. Soft palate is touching the posterior pharyngeal wall. CD is critically narrowed. EF is critically narrowed. So even with the asleep, the pharynx area is significantly narrowed. There is a significant reduction in the cross-sectional area of the pharynx. So we have taken the video of that in our clinical practice. This has been done in awake video laryngoscopy. See, epiglottis is totally lifted up. While you look during the sleep endoscopy, epiglottis is touching the posterior pharyngeal wall. There is significant decrease in the anterior posterior depth of the pharynx. So why it happens? Even with sleep or under anesthesia, why there is a significant decrease in the cross-sectional area of the pharynx. So this was the first publication of 2018 where they have measured the diameter of the pharynx by MRI, and at the same time they have measured the pharyngeal flow along with the EEG. They have used the EEG to define the sleep state. So they have defined the diameter of the pharynx and flow in the asleep state and awake state using MRI. So this was the first publication. Before that, all the publication either only for flow or only with the MRI. So combination of this both techniques happened this study. And what was the conclusion? So there is a significant narrowing of pharyngeal structure during sleep and wakeful phase in all OSA patients. During sleep, there is significant narrowing of this pharyngeal structure. And the commonest area of this decrease in the cross-sectional area of the pharynx is low retropalatal and high retroglossal. So these are the culprits. These area, low retropalatal and high retroglossal, these spaces are the culprit for airway obstruction. And what they did, they have plotted the diameter on the graph in a control and OSA group and in awake state and asleep state. Look at this graph. Here, this is the control group and in awake state. So, diameter was ranging around 30 millimeters square. Look, this is the diameter during inspiration, yellow line. And this one is the diameter during expiration. And it was ranging around 30. But what does it mean? See, look at this. So diameter was different during inspiration and diameter was different during expiration. It means that diameter changes with the tidal breathing. Diameter of the pharynx is different during inspiration and expiration. And during inspiration, there is decreased diameter, and during expiration, there is increase in diameter. And if you look at the schematic present, red is the expiration during expiration, and yellow is during inspiration. So, airway diameter changes with the tidal breathing. That is very important. And commonest area of obstruction is low retro-palatal and high retroglossal. And there is more of anterior-posterior narrowing rather than lateral narrowing. And both area, low retro-palatal and high retroglossal area, is critically narrowed during sleep and in patients with obstructive sleep apnea. So what is the clinical significance of this? See, in most of the patients, we are giving pre-medications, means we are giving sedation. Then we are giving IV anesthetic agents. So this significantly reduces the cross-sectional area of the pharynx. However, we are able to maintain the patency. But in certain cases, when we are not able to maintain patency, we can prevent the airway collapse. See, we know the commonest area of obstruction is low retro-palatal and high retroglossal. So if we are able to overcome this passage by passing a nasopharyngeal airway, optimal depth, we are easily overcome the retro-palatal space and high retroglossal space. So when you are suspecting this patient is not able to maintain the patency, before giving sedation, just insert the nasopharyngeal airway. That is how you can easily prevent the retro-palatal and the retroglossal obstruction. And you can easily overcome the obstruction. And as we discussed, so there is decrease in the anterior-posterior depth of the pharynx. That can be easily increased by inserting the supraglottic airway device. When you insert the supraglottic airway devices, it significantly improves the anterior-posterior depth. So that's the clinical significance of the what we discussed. And why there is a collapse? How to understand the collapsibility of the pharynx? So pharyngeal collapse is a complex interplay between the upper airway anatomy, pharyngeal dilator muscle control, and central nervous system ventility control instability. We will start with the upper airway anatomy. So as we discussed, the pharynx is a tubular structure surrounded by a soft tissue within bony enclosure. So whenever there is a normal soft tissue in a normal bony enclosure can lead to normal airway patency, normal airway size. Now what happens? In patient with the craniofacial anomalies, receding mandible. So bony enclosure is narrow, but soft tissue is normal. So what happens in such cases? A normal soft tissue in a narrow bony enclosure leads to compromised airway lumen. Now we look at with a different perspective. See, basically, patient with the acromegaly or obesity, there is the excessive soft tissue deposition at the level of soft palate, at the level of base of tongue, at the level of lateral pharyngeal wall and vallecula. So there is an excessive fat deposition inside the pharynx. So excessive soft tissue and bony enclosure is normal. So excessive soft tissue in a normal bony enclosure can again lead to compromised airway, compromised lumen. So in short, when you are handling the cases with the facial anomalies or receding mandible or patient with the obesity, both can lead to compromised lumen. That is called anatomical imbalance. And when you are handling the patient with anatomical imbalance, either with the craniofacial deformities or obese patient, so there is significant decrease in the cross-sectional area of the pharynx. And over and above that, when you deliver the sedation or anesthetic agent or election, which further reduces the cross-sectional area of the pharynx, which can lead to mechanical obstruction of the airflow in the pharynx. And that's the reason of having difficult mass ventilation. So that is the anatomical factors which causes compromising in the pharyngeal lumen. The second factor is the pharyngeal dilator muscle tone. So how all of us are able to maintain the patency even during sleep and during awake state. Have you ever think of how we are able to maintain our own patency and why many of the obese patients with OSA are not able to maintain their airway patency? For that, we need to understand the anatomy of tongue. So there are two groups of muscle in the tongue: extrinsic muscle and intrinsic muscle. So extrinsic muscle are genioglossus, hyoglossus, talioglossus, palatoglossus. All these muscles are anchored at the base of tongue. We'll discuss the significance of anchoring at the base of tongue at the later half of the session. And the extrinsic group of muscle are responsible for giving the position of tongue into the oropharynx, while intrinsic group of muscle are responsible for giving the shape of the tongue. So in short, position of the tongue in the oropharynx is decided by this extrinsic muscle. So along with this tongue muscle, another group of muscle, tensor palatine and hyoid muscle. These are called pharyngeal dilator muscle. Why it is called pharyngeal dilator muscle? Because during each inspiration, these three muscles, tensor palatine, tongue muscle and hyoid muscles contracts. And when they contracts during inspiration, the force of contraction is anteriorly. As the force of contraction is anterior, they dilate the pharynx posteriorly. That is the reason these muscles are called pharyngeal dilator muscle. So, and because of this contraction of the pharyngeal dilator muscle, we are able to maintain the patency in an awake state and during sleep. These are the muscles which maintain the airway integrity. Now, what is airway autoregulation? So, we have been discussing many times about the cerebral autoregulation, renal autoregulation. So, whenever there is an insult to the ischemic insult to the cerebral, that increases the blood flow to the cerebrum by cerebral autoregulation. That's called the cerebral autoregulation. Or whenever there is a ischemic insult in the renal vessels, it automatically increases the blood flow to the renal vessels by increasing the blood pressure. That's called the renal autoregulation. So what is airway autoregulation? So airway autoregulation, see, as we discussed, there is a compromised lumen in the patient with the anatomical imbalance. So whenever there is a compromised lumen, so by neurohormonal mechanism, it increases the force of pharyngeal dilator muscle. And as it increases the force of pharyngeal dilator muscle, it dilates the pharynx larger, or there is a higher dilatation of the pharynx. So higher the narrowing of the pharynx by neurohormonal mechanism, by airway autoregulation, it increases the force of contraction of the pharyngeal dilator muscle, and that causes the higher dilatation of the pharynx. That's called airway autoregulation. So most of the obese patients, in spite of having deposition of fat in the pharynx, narrow pharynx, they are able to maintain the patency by airway autoregulation. But few of them, patients with OSA, are not able to maintain. Why? That we'll discuss at the later part. So this is the factor. So first factor, we discuss about the pharyngeal dilator muscle. The contraction of the pharyngeal dilator muscle, anterior contraction, dilate the pharynx during inspiration. Another factor is a negative pressure during inspiration, which causes significant decrease in the diameter of the pharynx. And extraluminal positive pressure means whenever there is a deposition of fat in the pharynx, which promotes the airway collapse. Let's discuss how negative pressure causes the collapse. See, suppose this is a pharyngeal model, and this white portion is the pharyngeal lumen. So as we discussed, in obese patient or with the craniofacial anomalies, means patient with anatomical imbalance, there is decreased cross-sectional area of the pharynx. Fine. So this is the pharyngeal model where there is a decreased cross-sectional area of pharynx. Now what happens when this patient taking the inspiration? So they create a negative intrathoracic pressure when they breathe in, when they take inspiration. And this negative intrathoracic pressure causes a constant traction over the lung, over the trachea, over the larynx, and over the pharynx. So negative pressure inside the intrathoracic cavity is transferred up to the pharynx, which causes traction over the pharynx, and because of this traction, this pharynx get elongated, and as this pharynx get elongated, they causes again significant decrease in the luminal space. So negative intrathoracic pressure during inspiration in obese patient and with the craniofacial anomaly is the culprit for pharyngeal collapse. So higher the negative pressure, higher the chances of collapse. So again, we have taken that video in our clinical practice. See, this is the look at this. This is epiglottis which is lifted up, vocal cord is widely open, and look at this. The pharyngeal inside area surface is wide apart, open in a normal inspiration, in a normal patient. Look, it is wide open during normal inspiration. Now, what happens in obese? As in obese, when patient is taking the air in, during inspiration in obese, there is a negative intrathoracic pressure which is transmitted into the pharynx, and this negative pressure causes the airway collapse. So pharyngeal wall collapses inside. Look at this. Vocal cord is opening up, especially the anatomical imbalance. The pharynx is collapsing inside. Look, when this opens, it's going inside. Again, when it's open, it's going inside. So negative intrathoracic pressure is the culprit for pharyngeal collapse. And that is the reason when many times we are not able to maintain the adequate tidal volume in spite of having normal diaphragmatic force in obese patient, not able to maintain adequate tidal volume because there is a pharyngeal collapse during inspiration. And we are not able to maintain the oxygenation during induction or after giving sedation or after giving IV anesthetic agents. The airway collapses inside. So to maintain airway patency in such type of scenarios, if you are able to eliminate the negative pressure, you can easily ventilate the patient. So negative pressure can be easily eliminated by giving relaxation, and patency can be easily maintained by inserting the supraglottic airway devices. So eliminating the negative pressure by giving relaxation is been recommended by all the guidelines before rescue face mask ventilation, because giving relaxation improves the efficacy of mask ventilation. And that is the reason, if you look at the ASA difficult airway guideline, AIDA difficult airway guideline, European guideline, Canadian guideline, all the difficult airway guidelines are recommending to give relaxation before rescue mask ventilation. Now, let's understand the critical closing pressure of the pharynx. That's called peak crit. So peak crit is a pressure at which pharynx completely collapses. So as discussed, see, nasal segment is rigid, which is not vulnerable to change with the pressure. Tracheal segment is semi-rigid, which is also not vulnerable to changes with the pressure. The only structure which changes its size and shape or vulnerable to change with the pressure is pharynx. So now what happens? During inspiration, there is a negative pressure, the pharynx collapses inside. It decreases the cross-section area of the pharynx. Fine. So peak crit is the pressure at which pharynx completely collapses, and that is in a negative. So when pharynx collapses at -15, pharynx completely collapses, means there is no air space. That is at the pressure, that is called peak crit. And usually that is -15. So if our diaphragm generates the -15 pressure, which is not possible, diaphragm force or negative intrathoracic pressure reaches hardly up to -8 to -10. So -15 pressure, intrathoracic pressure, collapses the airway completely. But as is not possible in a normal patient. So that's the reason if peak crit is -15, is called a stable airway. But in certain situation, with deposition of the fat inside the pharynx, this critical pressure become positive. It means that with the positive pressure, pharynx collapse completely. And that's what happened in obese patient with OSA. OSA patient is having a peak crit in a positive pressure. And that is the reason to open the airway in OSA, you require to generate the positive pressure, which should be higher than the peak rate. And that is the reason most of the obese patients with OSA who require the CPAP requirement, CPAP titration should be more than the peak rate value. Then and then we'll be able to open the airway of the obese with OSA. So now, what are other factors which causes the collapse of the upper airway or pharynx? So even the position of the patient during induction promotes the collapsibility. If you induce a patient in neutral or extension and sniffing, it also matters. Let's look at the pharyngeal submandibular tissue or pharyngeal tissue, that is mainly tongue. Submandibular volume in a neutral position is this much of volume. But when you change the position from neutral to extension, because of extension, it reduces the submandibular tissue volume, and which is further reduced from extension to sniffing position. So if you compare the submandibular tissue in a neutral to sniffing, there is an almost 10% decrease of submandibular tissue in a sniffing position compared to neutral. It means that sniffing position, when you give the sniffing position, there is a less pharyngeal tissue, less submandibular tissue, and that because of less pharyngeal tissue, there are less chances of collapse. And that is the reason when you are managing the patient during induction or during TIVA without securing the airway, you should keep the sniffing position, not neutral, not extension. Because sniffing position reduces the submandibular tissue volume, and that is how it decreases the chances of collapse. Again, the vascularity of pharyngeal dilator muscle. As we discussed, the pharyngeal dilator muscle contracts during inspiration in an anterior direction, and that is how they dilate the pharynx. Now what happens? Suppose you are managing a case in a TIVA without securing the airway with the propofol infusion, and now there is sudden hypotension. This hypotension many times reduces the blood supply to pharyngeal dilator muscle, and because of decreased blood supply to pharyngeal dilator muscle, these pharyngeal dilator muscle are not able to that can lead to airway collapse. So even the change in the blood pressure decrease the perfusion to the pharyngeal dilator muscle, and that's the cause of pharyngeal collapse. And that is the reason when you are managing the patient in TIVA or during induction, you should maintain the blood pressure. So we have discussed about the pharyngeal dilator, we have discussed about the negative intrathoracic pressure, we have discussed about the extraluminal positive pressure. Let's discuss about the lung volume. What's the impact of lung volume on the pharyngeal collapse? Look, so whenever there is an excessive lung volume or high FRC like this, so which decreases the traction over the pharynx, and as traction is decreased, collapsibility also decreases. But when there is a less FRC, which increases the traction over the pharynx and which increases the chances of collapsibility. So when you are inducing a patient or when you are managing the patient the TIVA without securing the airway, always keep the position head up, as head up position significantly improves the patient FRC. As FRC increases, it decreases the lung collapsibility. So always induce a patient in head up position, which significantly decreases the collapsibility. So this is another important factor. So when we are pre-oxygenating a patient, I'm not talking about the induction giving propofol, just pre-oxygenation. So when we are pre-oxygenating a patient, it's our anesthesiologist tendency. What we do, मुंह खोल के लंबी सांस लो. Most of the time we'll tell them. So that is absolutely wrong technique. So when we are asking the patient to open the mouth and take breath, so when patient is opening the mouth, the tongue and submandibular tissue is shifted posteriorly, and which causes the airway collapse. So never pre-oxygenate the patient with open mouth. Always ask the patient to take a deep breath through the nose or the mask. So this thinking also needs to be changed. We need to ask the patient to inhale deeply from the nose when we are pre-oxygenating the patient. Now discuss, okay, all the patients are not having OSA, but few of the obese patients are obstructive sleep apnea. Why it is so? Why there is a difference? So for that, we need to understand obstructive sleep apnea. So obstructive sleep apnea is a cessation of airflow for more than 10 seconds or at least 5 times an hour, and which is associated with the fall of saturation for more than 4%. See what happens with the obstructive sleep apnea. A normal patent airway, this normal patent airway get collapsed during sleep. A neurohormonal mechanism makes the patient to wake up, which reestablishes the airway. It means that when we are handling the obese patient with OSA under anesthesia, and when there is a sleep, there is a collapse. And when patient is waking up, it reestablishes the airway. But when we are giving sedation, anesthetic agent, inhalation agent during induction or during TIVA, this protective mechanism, neurohormonal mechanism is gone away. They are not able to awake. And as they are not able to make themselves awake, they are not able to maintain the patency. And that's the cause of airway obstruction when we are managing the patient obese with OSA. And why there is only OS patient with obstructive sleep apnea is having a obstruction? Why not all obese patients? So that has been explained by this very interesting publication published in the Sleep Medicine in 2010, 10 years, 12 years back. So what they did, they took a Dexon MR image of the tongue. And with the Dexon MR image, it's very easy to pick up the regional distribution of fat in the tongue. This yellow portion is showing the regional distribution of fat, and this red portion is showing the muscle mass. So in two group of patients, they did a Dexon MR image. One obese with OSA and second obese control. And if you look at the BMI, it's almost matching. But obese control do not have obstruction, but obese with OSA were having obstruction. Now, what were the findings in a Dexon MR image? Look at this. So regional distribution of fat in obese with OSA was significantly higher at the base of tongue, while in obese control, in spite of having same BMI as obese with OSA, base of tongue fat padding is not there. So development of sleep apnea or obstruction is correlated with the accumulation of fat at the base of tongue. Now we discussed that all the pharyngeal dilator muscle of the tongue are anchored at the base of tongue. Now there is the accumulation of fat at the base of tongue. Because of accumulation of fat at the base of tongue, these pharyngeal dilator muscles which are anchored at the base of tongue are not able to contract efficiently in an anterior direction. And that is the cause of obstruction. So that is the reason obese with OSA develop the obstruction and rest of the obese are not developing the obstruction. So there are two culprits. One, negative intrathoracic pressure, and second, non-functional pharyngeal dilator muscle because base of tongue fat deposition. So we are predicting the difficult airway in terms of difficult laryngoscopy, difficult supraglottic airway insertion. But before, important is to predict the collapsibility of airway. We should be able to judge that if I induce this patient, or if I give sedation to this patient, or if we give inhalation agent to this patient en masse, this patient will be able to maintain the patency or not. So if you are able to predict this thing, we are definitely improving our safety margin. And is possible? Yes. That can be done by judging the hyoid position. This is the hyoid. So if hyoid bone is displaced inferiorly, that is suggestive of higher collapsibility of the airway. Let's discuss it out. So this is another interesting publication. Same in the sleep medicine. In two group of patients, obese with OSA and obese control, they have measured the mandibular plane to hyoid bone distance, which was significantly higher in obese with OSA compared to obese control. It means that if hyoid bone is displaced inferiorly downward caudally, that is suggestive of higher collapsibility of the airway. Why it is so? So in a clinical practice, you can just see that if hyoid is displaced inferiorly or higher mental distance is more, specifically in obese patient, that patient is likely to have a collapse during induction. Look at this. And also, as hyoid is going down, it increases the pharyngeal length. Now, why it increases the collapsibility as is hyoid displaced downward? See, as we discussed, whenever there is excessive deposition of the fat at the base of tongue here, at base of tongue fat deposition pushes the hyoid down. As it pushes the hyoid down, it increases the length of pharynx. As it increases the length of pharynx, it decreases the cross section area of the pharynx. So inferiorly displaced hyoid bone is an indirect predictor of airway collapsibility by indirectly suggesting there is a deposition of fat at the base of tongue and there is an increased length of the pharynx with decreased cross-sectional area of the pharynx. So pharyngeal patency or collapsibility is a complex interplay between the pharyngeal anatomy, pharyngeal dilator muscle control or activity, and certain factor, position, vascularity of pharyngeal dilator muscle, lung volume, and mouth opening also affects the pharyngeal patency. Thank you.